Hi, I'm Vishal Kishore, and I'm the Director of the Health Transformation Lab and Professor of Innovation and Public Policy at RMIT. Now, here at the lab, we aim to provocatively and rebelliously transform healthcare, playing with breakthrough technology, innovative and wacky ideas, and the most inspired and interesting people. My own interests lie in healthcare cybernetics, political economy, and the ethics and public policy of healthcare systems. But if you think that's interesting, just wait until you meet the rest of the team.
Lecturer in the School of Design and fellow in the Health Transformation Lab. I work creating living labs for social innovation in healthcare organizations.
Hi, I'm Charlotte Fligner and I'm an Innovation Fellow at the Health Transformation Lab. I bring my background as an architect and also in design anthropology to the lab's strategic design and innovation work.
Hi, my name's Jess Chatterton and I'm an Impact Fellow here at the lab. My background is in biomedical research as an immunologist at the Doherty Institute. My interests are sustainability, systems thinking, and science communication.
Hi, my name is Nicolas. I'm a development economist, originally from Argentina. I work as an Impact Fellow, researching issues in the intersection of economics, public policy, innovation, and political philosophy.
My name is Brad Crammond, and I'm the new lead for Insight and Research at the Health Transformation Lab. I've got a background in law, public health, social theory, and biostatistics, and I've done a little bit of infectious disease modelling on the side as well. I'm interested in mostly everything, but particularly how we can combine thinking from across disciplines to arrive at innovative solutions.
All right, we might get started. Welcome, everybody. My name, for those of you who don't know me, my name is Vishal Kishore. I'm the Director of the Health Transformation Lab, and it's a real pleasure to welcome you all here today for a very fun conversation. Before we begin, please just allow me to offer my acknowledgements to the traditional owners of the land on which we're all variously meeting. For those of us at RMIT, it's the people of the Boonwurrung and the Woiwurrung language groups, and we take the dust from the feet of elders past, present, and emerging. So once again, it's wonderful to have you all here. Welcome to Open Labs Online, or as we have, against my strong objection, started calling it OLO. And we're in for a real treat today. It's a real pleasure for me to introduce to you a new member of the Health Transformation Labs team. Dr. Bradley Crammond is going to spend some time talking to us today. Brad's the newest member of the team. Brad is joining us as the lead for insights and research at the lab. And Brad is one of these extremely hybrid kind of people that we love. So he has legal training, public health and public health law, human rights, but then also social theory, biostatistics, epidemiological modeling. He can code in at least 4 different languages. He has tattoos all over his arms, which he's sensibly covered today. He is precisely the kind of person that you want to hear from and that we all want to spend time with. So it's a real thrill to have him joining the lab. For me personally, it's the culmination of more than a decade of knowing Brad and playing with ideas with Brad. And so it's so thrilling for us all to be together. He's going to spend some time talking to us today about this niche area that's gone mad, this area of infectious disease modeling, which has moved from something that a bunch of strange people in cardigans do in the corner of health systems to really something akin to, I don't know, either Lord of the Rings-esque control of the environment, like the policy environment, or at least celebrity-like media presence in the context of our current pandemic. While other parts of the world are really struggling with, how do they overcome ideology or apathy in thinking about pandemic response, we in Australia and certainly in Melbourne have had a very different kind of environment. We've had an environment where statistical models have become a part of the daily rhetoric of government when speaking to populations and when justifying and talking about their particular policy actions. We're in a world where, our literacy about things like rolling 14-day averages and replication numbers have become kind of reached a high point. But in that kind of context, in a context where we are overawed and overwhelmed by all kinds of different statistical modeling that purport to tell us something about the world and to tell us something about action that we might take, it's perhaps very interesting for us to take a moment to explore the limits of those models and to understand these models in a bit more depth. What are they really good for, and what are they absolutely dreadful at doing? And so to guide us through a bit of a conversation, which we hope you'll all participate in as we go, I'd like to invite Jess Chatterton, who many of you have met before, a fantastic member of our team, who will be engaging in a conversation with Brad, sort of a Parkinson-style interview. So with so much of background,
I can only hope.
And Brad.
Thanks, Michelle. Thank you. Welcome, everyone. I wanted to just start with a couple of housekeeping notes so that we can have a fun and interactive event this afternoon. So if you can just keep yourselves muted unless you have a question, feel free to unmute and ask a question anytime during the next hour or so. There's also a chat function. The button should be in the bottom right corner of your WebEx window that you can post a question in there and we'll get to it in due course. It's also really lovely if you'd like to have your video on. That helps us really interact with you a little bit better, and it gives us some feedback during the presentation. So please, if you feel comfortable, switch on your video. All right, so let's get started. Thank you, Brad, for volunteering to share with us some of your expertise today. We're looking forward to learning from you. So let's just start with some context. So first of all, tell us a little bit about yourself, why you ended up learning about infectious disease modelling and what it is. How did you get into it?
Thank you, Vishal, for the introduction first. I'm not sure that I can ever live up to it. It's an interesting question. So I decided that I wanted to learn statistics because I realized that people don't really care about what you have unless you can prove it with numbers. And I think that's absolutely been borne out during this pandemic. Infectious disease modelling, when I randomly decided to take a few classes and take a job doing it, was a niche area. It's something that is mostly focused on diseases like Ebola. I always thought that Ebola was a really fascinating disease, and I started doing it during the West African Ebola outbreak. And so it was just how can I understand this insane thing that's happening in the world? Is there something that computing and statistics can tell us that we can't otherwise learn? And so I picked it up and spent the last 12 months working on Group A strep circulating in remote Indigenous communities, which is the modelling that I've been doing. And that's kind of why. There's no great reason other than it's fascinatingly interesting, and now we all care about it like it's Melbourne Cup and everyone's got an opinion on what the unknown is. Absolutely.
Well, when it starts to affect our day-to-day, we really start to want answers, I guess. So what is modelling? What's the process about? Can you give us some examples of how you might talk about modelling, the language that's important? I know we've come to terms with a few of the different pieces of language that are described, but can you summarise it for us so that we can start to get our head around it?
Sure. So I'm going to put up a slide because I think that is the most easiest way to explain it. And if I do that, so this is a paper about the Italian outbreak of COVID, but it has the generalized disease model that gets used in modelling. So the first reason why we have these disease models and why we don't use normal statistical methods is because we can't see the disease process as it tracks forwards. So one of the issues is that you never get all of the cases identified. And so you're always working with a kind of partial data set. The other thing is that most statistical methods presume independence between each of the different data points. So if you're doing standard epidemiological research around the association between fast food outlets and obesity, you're kind of presuming that each obese person is independent of every other obese person, non-obese or overweight or whichever category it is. But in infectious disease modelling and in infectious disease spread generally, that's the precise opposite. We know that each person is getting it from someone who already had it. So at each time point, there's complete statistical dependence. So instead of being able to use a kind of static statistical model on a data set, they use these dynamic mathematical models. Now, the way that works is you have everyone in a susceptible category. So a susceptible person is someone who can get the disease. And then most diseases move from that into being exposed. So you've had an exposure, but you haven't become symptomatic or you haven't become infectious yet. And then you move into the infectious category, and then the number of people in the infectious category kind of determine how many people move out of susceptible. Because the more infectious people there are, the more people they come into contact with, and so the more the infection spreads. If people get quarantined, then the spread will slow down, and then the ultimate outcomes of the disease are always recovery, or if it can be fatal, then it's death. In some things, like in Ebola, you'll have another category after death to burial because people stay infectious after they're dead. And you can split these up in a variety of different ways. You can say that healthcare workers are a different category, that they're more or less susceptible, they're more or likely to spread it, depending on the different disease. And then what you do when you model is you have all of these equations that are here on the right, and your computer solves them for each time step. So each day it calculates there are this many infectious people, and so they infect this many susceptible people, and that kind of runs through. And you end up with a set of curves as the disease kind of progresses through. Now, why do we want to do this? What information does it give us? One is the fabulous number, the R0, that everyone talks about all of the time. What that means, so the R0 is, on average, in an entirely susceptible population, how many people each infectious person will infect. So Ebola has an R0 of about 2.8, and measles has an R0 of 16. So measles is insanely infectious, and one of the things about an R0 is the notion of herd immunity that's been bandied around. The number of people you need immunised or infected and recovered to get herd immunity is a function of the R0. So to get herd immunity with measles, you need like 98 and a bit % of the population to be vaccinated or recovered. And that's why we just can't ever get rid of measles. That's why it only takes a few small clusters of people to refuse vaccinations, and measles kind of keeps kicking along. Whereas for other diseases like whooping cough, it's like 80% makes a difference. But you can't see the R0. You can only get that from doing these modelling bits afterwards.
Once you have data on
Once you
the
have
cases.
Data, exactly right.
Yeah.
And so you fit it to this model, and then you can extract the R0 from that.
And so I know we're talking a lot about R0. Are there other variables that in here that could be useful to us besides R0 that we should be thinking about?
So every single one of those Greek letters is a parameter that goes into the model, and there's many more than that besides. So one of the things that's at issue in this Victorian outbreak is the average number of contacts that a person has. Mm-hmm. So if your model assumes that every person has 100 contacts a day, then your disease will spread out very quickly. And if it assumes that you have 3 contacts a day, it's going to spread out really slowly. You often don't have data on that. Sometimes people will use like the Google and Facebook data that's available nowadays, but often that's a guess made by the researchers. Some of these ones in the slide are physiological things, so how long it takes for someone to go from being exposed to being symptomatic or infectious, but a lot of them are kind of social. So this delta is how likely you are to get people before they infect others. So like, are you going to successfully find them and quarantine them? And that is going to be affected by policy and all those other sorts of things.
Yeah, and I understand that the recovered factor would depend on whether we know that there's immunity generated as well, which is still another question in there of whether a recovered person is protected or is still susceptible. So that could actually just be a loop.
Absolutely. So there are lots of different versions of this model. So some of them just have susceptible, infectious, and then back to susceptible.
Right.
So
interesting.
Like group A strep generally follows that kind of. There's very brief immunity. Some of them will loop back. Some of them you get lifelong immunity. Just like we know those sorts of things.
Yep. So I have heard. Oh, sorry. You go.
Oh no, this is an aside, but the malaria model is fascinating because there's a separate model for mosquitoes next to and parallel to this model, which is about the most complicated thing to model, I think.
I can imagine. So I've heard the word assumptions used a lot around modelling. So talking about an assumption around the number of contacts or the infectiousness of a virus. Why do we need assumptions, and why are they necessary, and what could be the problem with having assumptions in a mathematical model?
So there are, this we're going to talk about and spend some time on. There are lots of different things that go into a model. Some of them you have to make assumptions because life is just more complicated. Like the point of a model is that you're abstracting from real life and you're trying to get at the core of something that's important. You can't model absolutely everything, so you have to assume that most people act kind of the same way. That if you have people who are vastly different in their behaviors, then it's difficult to include them. Generally, you're assuming that everything is going to be kind of regular among people and amongst them. If you look at this model, this is the model that is responsible for. So this is the model that was published in the MJA and which was used to set our roadmap for going out. So all of those numbers that the Victorian government is looking at, including at the moment the less than 5 cases per day and the less than 5 mystery cases over 2 weeks, all comes from this model. Now, so many of these we don't have data on and have to be assumed. So things like, what is the compliance with isolation from the Victorian population? That's something that we have to guess. How
what
more
is
or
the
less
number there out of curiosity?
They've said 95% of people will comply with isolation.
Yeah, interesting.
They've got track and trace efficiency as 25%. They have an idea of anxiety. So as there are more cases, people are more likely to stay at home because they get anxious. That's an assumption. We don't know precisely what that's going to look at. They have transmissibility at about 25%, which I think is high. And this has some data because there is some data available. But in order to get an answer for every single one of these things would require so much qualitative research that by the time it was done, the entire thing would be finished. Like, we just don't have a way of figuring out the precise parameter for how much less infectious an asymptomatic person is compared to a symptomatic person without doing a huge study of that. Like, these are all guesses. And that's totally fine. And it's entirely necessary because you can't ever build a perfect model that completely simulates real life.
So this is normal for epidemiological modelling. There's always a lot of unknowns.
Yeah, absolutely.
Yeah.
And I think part of that is because you're not trying to give, despite what's happening at the moment politically, the point of a model isn't to perfectly predict the future. It's to give you a counterfactual. So if a certain number of things happen, this is what it might look like. If certain like certain kind of contexts exist, it will spin out in this way. So when this model was released and the government said we needed to do a particular roadmap, they could have said, if certain situations obtain, then this is what it's going to look like. And if situations change, then it won't look like that. But that hasn't been the way things have been presented. There's been a real reliance on the model giving us specific information about what's going to happen into the future without a lot of thought about the assumptions in the model and what might happen if some of those assumptions don't pan out.
Okay. Fascinating. If anyone has questions to clarify from Brad, this is a lot of information. Feel free to pop them in the chat. I'm going to move on to a bit of a trickier question about what are some examples of good or bad models. Do good or bad models exist? And what makes them good or bad? So we've talked about that obviously there's always going to be some unknowns in modelling. So how would you describe the strengths and weaknesses of the current model, or how we could have improvements in the current modelling?
So I think the official answer would be there's no such thing as good or bad models. It's just about how they fit circumstances. But
Right.
this is a bad model. This is a terrible model. This model presumes that every single person in Victoria, shrunk down to 2,500 people, are randomly running around, bumping into each other and giving each other COVID. There is absolutely no separating out of different types of people. We don't have healthcare workers, we don't have aged care workers, we don't have aged care residents. Now, we know that at least 10,000 of our 20,000 cases have come out of aged healthcare, which means that when you're modelling this, we absolutely don't have people running around the community getting cases at their local Coles. That's not what has been happening. It's not what's been driving the second wave. If you think that, if you treat the population as if it's homogenous and random, you might think that a 6-week lockdown would be entirely successful at wiping out the virus. And indeed, that's what was predicted, and that's why we got stage 4. Obviously, as we know, at the end of that 6 weeks, that didn't succeed. And the government reran this model, as they tell us, and they said, okay, what we now know is that 12 weeks, we're going to have this time frame, and at the end of 12 weeks, then we should be okay. And within 2 weeks of saying that, the case numbers had dramatically dropped off and had gone outside the confidence intervals of this model.
Right.
The reason for that is because the workplaces involved all took action to vastly reduce their transmission events. So
for those people who don't, sorry, I was going to say, please. For those people who are not maths people, can you explain what confidence intervals are?
Absolutely.
Because it might not be an intuitive thing to understand from models.
So what it means in this circumstance is this is all these stochastic models. Basically, every time someone bumps into each other, there's a probability that they transmit it. So they run this model 1,000 times, and the confidence intervals are in 95% of cases we would expect the circumstances to be within those boundaries. So you have your kind of middle, and your 95% is the confidence, the boundary around what you expect to happen.
Yeah, so it's about sort of likelihood of that result. Yeah.
Yeah, absolutely, according to the model. And the precise interpretation can be complicated, but that explains it clearly enough. So what it means is that there's 2.5% likelihood on either side, at the top and the bottom, of a different outcome. So they're saying that of the times that we've run it, that's what we expect to see. For the model to be so wrong so quickly would require it to have misspecified what was going on in some way. And indeed, that's what has happened. It doesn't reflect what's going on in society in Victoria. And so it didn't predict that the virus would continue when work under control, and didn't predict how quickly it would drop when the federal government stepped in and spent $100 million on aged care to clean it up. And the doctors of Victoria independently almost started closing tea rooms and cleaning up hospitals.
Right. So we've had individual interventions that were not guided by the original model.
Yeah, there's a healthcare worker protection task force that still hasn't come to its final conclusions, but it didn't. It took, so when Frankston Hospital fell over in early August and they had to furlough 700 staff, every other hospital in Melbourne went, oh my God, we better try and make sure that doesn't happen.
Okay, right.
And so
yep, sorry.
So this is a bad model because it's not reflecting what's going on.
So besides the healthcare workers, which obviously is looking like a big missed factor, are there other factors that you think are critical that we should be thinking about?
So the idea of random homogeneous mixing is a very strange one. It existed when computing power wasn't sufficiently advanced to be able to model anything accurately. It's like a hangover from the early days of infectious disease modelling. We know that I don't have the same likelihood of bumping into you as I do the person in Coles, as I do a person who lives in Colac. Like, it's absurd. And so to base a model on such complete random mixing. In this model, the only thing that can happen is that 100% of people get infected. It just, there's nothing to slow it down. Whereas in the previous model, the way the equations work out is that the disease will or the virus will ultimately kind of run itself out, that the infectious people won't come into contact with enough susceptible people, and you don't get 100% infection. In this one, 100% of people get infected. The only thing that you can do is lock them down. But I think this is perhaps the most interesting one to talk about in terms of good or bad models, because this is a good model being used for potentially bad purposes.
Okay.
So this is the third model that the Victorian government has promoted to explain what's going on. So the red and blue lines indicate if Victoria was released from restrictions to the same level that New South Wales has, these are the things that we can expect to happen. And so, according to this model, if it had been let out on the 14th of September, down the bottom here, we would have had an 86% chance of the virus massively taking off, and we would be above 700 cases a day within 2 weeks. Which begs the question as to what New South Wales is doing so much better than Victoria that they're at the same rate and it wouldn't spiral out. And the same thing for if we had been released in the 28th of September, pushing forwards, we would have a 40-ish% chance of this spiraling out of control again. This model is incredibly sophisticated. It's thousands of lines of code written in Python. They have separate transmissibility probabilities for most circumstances you can think of. It's different if you go to church with someone compared to if you're a healthcare worker compared to if you're in the supermarket.
Okay.
But they do seem to think that people are getting a lot of average daily contacts, probably more than you would expect. But even if every parameter that we can look at looks exactly right, and there's nothing in there that screams they've misspecified their model, the conclusion that letting us out at the same level of New South Wales would result in such a different result is surely something that needs to be investigated. That seems either completely wrong, or Victoria has done something terribly, terribly wrong to put us in a different position.
Right. So there's factors that we're not modelling that still have an impact.
There are always factors that we can't model, and often it takes a long time to know what all of the different things are. With Ebola, we've only recently discovered what the animal reservoirs are and the precise disease dynamics, simply because until that outbreak in 2015, there hadn't been a long enough outbreak to perform all of this sort of research.
Okay.
And so there's always something that could or should be in the model that we don't know yet. And so if the results of the model look stupid, it's always worth considering whether or not they are.
Right. So we have a question here about whether Victoria and New South Wales are sharing and comparing models.
So the same group was doing all the national models until relatively recently. The previous model, this one has been specifically designed to look at Victoria, and it was also used to model New Zealand and compare the two.
Yep.
This one hasn't been applied to New South Wales as far as I've seen anywhere, and I haven't even seen any specific modelling for New South Wales moving forwards. There's kind of not a lot of value at this point. Like, if on top of the virus and it's not really spreading out, there's not a lot for the model to tell them. Like, one of the analogies I like to use is, at a low number of cases, this is detective work. Like, you've got to find individual cases and find their contacts and stop them from continuing to spread it. You kind of need modelling at the population level to see what overall the average result of something will be. You can't get an average from 5 or 10 people and spin that out to 5 million.
Right. So would you say that there is a limit of detection, in a sense, where if the case numbers are so rare that the model just wouldn't be applicable? Is that a fair thing to say?
For sure. So right at the end of the first wave, the original modelling was showing that, like, pretty much anything could happen. That the numbers had gotten incredibly low, and it looked like the virus would run out, but it was very uncertain because there just wasn't enough information to really predict anything on.
Yeah, okay. Cool. So why do you think, I mean, both governments and just normal people like us really struggle to understand complex models? What is it, like, we know they're complex, but what is it about this stuff that is so hard for us to get our heads around and grapple with?
It's an interesting question. Partly, of course, the silly answer is that they're complicated. The second is that they're quite counterintuitive. So this set of equations, you can't solve algebraically. Like, there's no way to get your head around the way this works. Like, they're differential equations. You need a special solver in your statistical program. Your computer can do it and can do it relatively rapidly, but there's nothing intuitive about the way that it works. The newer ones are, like, to read the text of this model is just walls of parameters and what happens, and, like, if this happens, then that happens, and if something else happens, then we go this way. And so there's no, like, lay version of it.
Yeah.
In order to understand what's going on, you have to dig into the model code, and for obvious reasons, not that many people learn to code in Python and have an interest in infectious disease models, or are stubborn enough on a Sunday night to read through the model and find out why it's so stupid and why my kids still can't go to school.
Who would do that?
Who would do that, honestly?
Who would do that? We have another question. So how are testing numbers related to this modelling? So how do we integrate testing data with our case number modelling? Good question, Shefton, thanks.
So what you do is test. Normally, when we're looking at the exposed and infectious, you have a parameter for the number or the percentage that are ascertained. So the percentage of cases that you're finding. So in your annual flu outbreak, very, very few people get a flu test or get diagnosed with the flu. So you're always dealing with, there's a proportion of cases that get notified as flu cases. From that, there's a proportion of people who go to the doctor sick but don't get a test. There's a proportion of people who stay at home and don't go to the doctor. And so you are always dealing with this incomplete information. When you have 20,000 tests a day, you can be more confident that the number of cases that you get represents the true number of cases. And so you can build in a parameter, which is like the probability of detection. That means that you don't have a lot of unknowns who might be infecting those in the susceptible category. So basically, the more test results you have, the more confident you are in your predictions and that your model represents what's actually going on. The only problem in that is if your testing numbers are routinely missing certain groups of the population. So one of the problems that we had early on in May in Victoria is that people with uncertain visa status didn't want to go and get tested because they were worried that if they got tested, then they might get a call from Home Affairs to ask why they were still in the country or what was going on. So the testing blitz in Victoria might have missed a number of the high-risk individuals because they were afraid of coming and getting tested. So testing numbers are one guide to how certain you should be, but they're not perfect. Like if your sample doesn't represent your whole population, then you can run into trouble. You can be like more certain than you should be.
Yeah, it's false confidence.
Indeed.
Risky. Interesting. So is there anything else that we really can't tell from models? Like what, as a person who's not a policy maker or an epidemiologist, what should I be interested in out of this? Is there anything, or is there a different set of statistics that inform me better than the modelling?
There's not a better form of statistics. There are better models. So one of the things, like there was an article about this 2 weeks ago. One of the things is that the Victorian government appears to be cherry picking its choice of model. The model based on this diagram suggests that we don't need any more lockdown and we could be safely let out. But there are all sorts of things, like types of information that we should be looking for to see whether or not the model assumptions are true and correct and whether or not we should believe them. So this model has copped an enormous amount of derision, I guess. A number of very important people have pointed out why it's wrong, and in large part, the Victorian government has distanced itself from using this model at all. This one, we should be asking, what are the assumptions that underlie this? Why is it that it's taking off so quickly? It would be an entirely reasonable question to ask the Chief Health Officer at a press conference. What is the difference between Victoria and New South Wales that means that ours would take off so quickly? Like, this model is being used to justify continued lockdown. And if that's necessary, I think I can speak for everyone when I say that I would hate for us to end up with 700 cases a day again. Like that was miserable and huge numbers of people died unnecessarily. And if extended lockdown is required to avoid that, then fair enough. But we should be asking, why is that the case? What is it about Victoria that makes this at all plausible? And so I think the models should prompt us to ask questions. Like they don't tell you exactly how the future is going to run. They're a prompt for, why does that look like that way? What is the problem? What's going on here?
Yep, makes sense. Does anyone in the audience or any lab members have a question for Brad? I have a couple more, but giving you guys the opportunity to jump in if you like.
Stop sharing.
Chefton, any insights into the elimination approach? Don't know how many insights we have. Brad, what are your thoughts on, do you think the government is thinking about elimination without saying it?
I think they have been. And I think like they've been pretty hopeful about it. I think at the height of this, there were two Melbourne professors kind of fighting over elimination, I guess. So Professor Tony Blakely is an epidemiologist. He's the author of what I keep calling the bad model. And he's arguing from kind of late March that elimination was the way to go. Generally a little bit skeptical of white men with secure employment telling everyone, if you just stay in your houses, and I'm sure he has a terribly nice house, then this whole thing will be fine, with no thought. And I guess this is one of the things that's not in the models, all the people who are stuck at home with violent partners and abusive parents and all the rest of it. Like, there's a terrible mental health toll to lockdown. And this model conceives of health as the movement of a pathogen, and
being disease-free,
not about individuals who are suffering in a variety of ways. So Professor Blakely has been arguing for elimination, and there's a professor at the Doherty who is a career infectious disease modeler called Jodie McVernon, and she was on Q&A saying, we did eliminate. So in Victoria, we eliminated the first wave, and a single case got out of hotel quarantine, and we ended up with this. New Zealand had clearly eliminated COVID and then still ended up with a bunch of cases. Even if you eliminate it, that's not going to relieve us of the responsibility of testing, tracing, being aware of what's going on. New Zealand is in the position where if they want to reopen their borders, and their tourism industry is desperately asking them to open their borders, they will have to implement some restrictions in case an Australian brings the virus to New Zealand. So until there's global vaccine level, like a high rate of vaccination, we're always going to be worrying about this. Or even if you eliminated it, you can only isolate yourself like Western Australia for so long. And then at some point, if you're going to let people in and there's any risk of it, then you're going to have some restrictions so that it doesn't spread completely kind of unfettered.
We discussed this a bit in the lab. Sorry,
No, go.
There's a slight lag making it hard to tell. I was just going to say we discussed this a bit in the lab where the virus has created this very insular thinking around where our borders lie, and shutting down borders and eliminating the virus in our city or our state or our country, but actually because we're part of a global, community, you're right, like there's never true elimination if we ever hope to be part of the rest of the world again. So there's that balance of focusing on getting rid of a virus in Melbourne, for example, but in reality, we have to balance that with the responsibility, as you said, for managing the ongoing potential for transmission. So that's an interesting long-term question.
Raises that very strange question about how we've been very moralistic about return travellers.
Right.
Overseas and sought to come back, as if they were horrible people who just didn't love Australia enough to stay here all the time, rather than as people who were just unlucky among all the travellers in the world to be stuck overseas when this hit. And at some point, there are still thousands of people trying to get back to Australia. And our hotel quarantine is not significantly better quality than it was when this all happened in the beginning. So at some point, we're going to end up with the same problem. We're going to need to keep testing and tracing. And so hopefully we can do that when we've still got 5 or so cases a day. I hope.
Yeah, well, the more data, the better. Murray Evans has asked, what about international modelling, and how does that compare to Australian modelling?
What is different is that in a lot of places there were actually community outbreaks. So it's very difficult to compare America and Europe to Australia on this because we haven't really had wholesale community transmission where it's being driven by people going to the shops.
Right.
And so the last model I showed, which shows the rapid takeoff, that was actually designed in the US and has been adapted to Melbourne. And it's possible that one of the reasons for the big takeoff is that in America there is a really generalized epidemic, whereas in Victoria it's mostly clustered. And so the model might be tuned to different circumstances. I'm sure everyone saw that an Excel spreadsheet broke the UK, and now it turns out that they've been having 7,000 cases a day for the last 4 weeks, 5 weeks. The scale of other countries is completely different. Like so many more cases per capita. And I think what makes Victoria fascinating is Victoria is what happens if you do all the lockdown, everything that's been recommended, and this is what you've got left at the end of it, which is cluster after cluster moving around. So the modelling compares, but the context is quite different.
Yeah, and as we talked about, I think it was earlier today, the cultural factors, environmental factors, there's a lot of variation between cities around the world that make it tricky to make comparisons directly.
And I think particularly in Australia, part of it is about density. When COVID was first moving around the planet, Americans and Europeans living in apartment buildings in winter, sharing lifts, was a completely different context for spreading the virus compared to Australians in summer, most people living in separate houses, not a lot of high density living, which just makes the disease dynamics very difficult to compare.
Yeah, and our major populations are quite spread out relatively. We have a question from James. Do you think we would have got the same outcome making decisions based on hunches and opinion rather than on these models, particularly if the models are so flawed?
I think we would have gotten a better outcome. I think the model
controversial
with false confidence in certain aspects. I think the fact that the early model said that the first wave was just going to run out gave everyone a sense of complacency. I think the second set of models that showed that 6 weeks of lockdown would be sufficient to eliminate the virus prompted a lockdown and discouraged other interventions because they won't be necessary anyway. And even today, I think the overall emphasis is there's only lockdown or no lockdown because the models are too blunt to compare anything else. What we don't have clearly at all is what are the other things that we could do to make sure that this Chadstone outbreak doesn't happen? Like, how is it that a cleaner spreads it to a butcher who spreads it to a bunch of different people? Why are staff moving around in the way that they were, and how are people not being safe? When the discussion is just lockdown or not lockdown, we're not being creative about how we could deal with it, how we could focus on risky areas. We're just kind of applying the same model to everyone. And so the model encourages us not to think about specific things like that.
Yeah. Do you think that in the future there's going to be some classification of, like, a way for people during their daily life to classify their levels of risk, to say, oh, well, I'm going to the supermarket and I want to go to the movies later. So, my level of risk is a 6 out of 10 today. So maybe tomorrow I should stay home. So my risk is a 3 out of 10 or something. Like, do you think a more general way of us understanding our own risk profiles would enable that like specialization for different cohorts, or is it up to the government to decide who's at what risk? Like, where do we put that responsibility?
So people care about their own health, but people care about their own health in different ways and with different amounts of knowledge and with different amounts of caring. It is a peculiarly upper middle class thing to think that health is the number one priority. And so one of the things that health sociologists will talk about is, in a lot of public health work, no one will countenance the idea that you might rationally choose to be a smoker.
Yeah.
You might weigh up the risks, decide that only 1 out of every 10 smokers gets lung cancer, and you're willing to roll the dice as a totally rational decision. The idea that you might make rational decisions against your own health is something that doesn't exist in the literature, despite the fact that people do it all the time. When people go to a Black Lives Matter protest to fight police oppression and lose their eyes and get hit with tear gas, those people are deciding that there is a political point here that is more important than their immediate health. And so when people are given an opportunity to weigh up risks like that, what we know is that people will go, well, sure, I smoke, but I otherwise exercise and eat well, so I'm sure I'll be fine. Like, people do think about their risks in complex ways. And so we kind of already have that, and people will be doing that, and people will decide whether or not they think a cinema is safe or not. But we also know that sometimes in the heat of the moment, people make really poor risk decisions, and you kind of can't rely on that as a public health strategy.
Yeah. So there are, oh, I don't know if you're frozen. Oh, yeah. Keep going. Sorry, you were just frozen.
No, I'm done.
Oh, okay.
I think my time's about to die.
All good. So there is an element of we have to rely on policymakers to put in the more generalized public health strategies, but there is an assumption under there that people do care about their own health enough to generally make good decisions.
There are certain things like contact tracing is clearly something that individuals can't do for themselves.
Yeah.
Like, you don't have the power, you don't have the capacity. Infectious disease control, which are like right at the core of what we expect governments to do for us. So ever since like Florence was locking the gates and quarantine got its name, we've expected governments to take some sort of collective action to protect the public's health. Like, we've had leper colonies for thousands of years. Like, we know this whole kind of isolation thing is a thing that governments do for us. And so there are certain things that we couldn't individualize, even if we wanted to, that they need to be kind of centrally organized. And so, yeah, there's an element of this that requires government intervention. And that's why they exist. Like, that's why we agree to hand over our taxes and have the government and give them power and listen to them. There are certain things that they need to do. Like, that's what public goods are. And infectious disease control has been one of those core public goods for 1,000 years.
Yeah, definitely. All right. Does anyone else have another question? We're running into our last 5 minutes.
I can see Shefton's question, and the answer is no, you can't. You absolutely can't eliminate the politics involved. I completely agree. You can't build into the model that one layer of government will hate the other layer of government and use it to score political points.
Spread evil rumors or something.
Throw them under the bus. Indeed.
All right. Well, if no one else has any other questions, I think it's about time to wrap up. Thank you so much, Brad, for sharing some of your insights.
My pleasure. It's fun.
Thank you all for coming along and sending through your questions. I hope you all learned something new today. If you want to keep up to date with what's happening in the lab, keep an eye on our website, healthlab.edu.au, and our social media. Thank you so much for joining us again, and we'll see you next time at Open Labs. Take care, everyone.
Cool, thanks.